Hey everyone, you're very welcome to today's tipsRO webinar. We're just going to wait a couple of minutes while people are joining the meeting, if that's all right. So just bear with us. Thank you. Okay, so I think we're going to start and others can join us as it's now 3 minutes past the hour. So you're very welcome to today's webinar for tipsRO. And today we are speaking about global professional issues, which was a special issue in tipsRO relatively recently. So we're delighted today to be joined by two of our authors from that special issue. So first of all, I'm going to introduce you to Dr. Laurie Elit, who is Professor Emeritus in the Department of Obstetrics and Gynecology from McMaster University, Hamilton in Canada. She is a gynecologic oncologist, and she joined the staff at Mbingo Baptist Hospital, which is part of the Cameroon Baptist Convention Health Services, first of all in 2016 and then more full-time in 2021. She is faculty for the Pan-African Academy for Christian Surgery at the Mbingo site, and she is Vice Dean for Research at the Baptist Institute for Health Sciences, where she is also the Programme Lead for the Masters in Public Health. And we're also delighted to be joined by Laurie's colleague, Dr. Ntumsi Tontu. He's a young and early career clinical and radiation oncologist who is also working at the same hospital. He qualified as a medical doctor from the University of Buea in 2016, and then joined the CIMS residency program as an internal medicine resident. He then subsequently travelled to South Africa in 2019, where he attended the University of Stellenbosch and obtained a Master of Medicine degree in radiation therapy. He's also a fellow of the College of Radiation Oncologists of South Africa. And he has a really good understanding of the challenges as well as the opportunities in the African oncology landscape, which is so important for us to hear about today. And it's his strong belief that every patient with cancer deserves to get the treatment they need, irrespective of where they are in the world. And his drive is to contribute to narrowing the disparities in survival outcomes that exist in Africa relative to other regions of the world, such as Europe, through collaborative research, training and advocacy. And his current research interests are in breast cancer, cervical cancer and prostate cancer. So you're both very welcome to today's webinar. I'd also like to introduce my co-chair, who is Tsang, who is deputy editor here at tipsRO. So Yat will be taking your questions later on. So just to say that if you do have questions as we're moving through the presentation, we'd like to get to the end of the presentation first, so that's okay without any interruptions. So you can use the Q&A function. You'll see it there at the top bar on your Teams. You can use a Q&A function, and Yat will come to those questions at the end of the presentation. So if I could just ask that the holding slide is removed, please, and then I can start sharing my screen. Okay, so just one moment as we get ready to go. So Laurie and Ntumsi, you can let me know when you can see that and then give me the instruction to move forward for you. Thanks.
Thank you very much for inviting us to present. We're presenting on behalf of the Mbingo Hospital Radiation Oncology Planning Team, and we're going to talk about the advancing cancer care in Cameroon. Next slide, please. You've already done our introduction, so we'll ask for the next slide. What we hope to cover in the next 30 minutes or so is an overview of some cancer statistics for Cameroon, the current state of radiation therapy in Cameroon, who is Mbingo Baptist Hospital, and what is the status of the Department of Radiation Oncology at this juncture. Next slide. So the total population in 2024 of Cameroon is 29 million people. We know from Global Can that there are roughly 19,500 new cancer cases and almost 13,000 cancer deaths. But you need to understand that there is no systematic classification or accumulation of data on cancer cases in this country. So these stats are probably grossly underrepresented. We know that in men, the most common cancer is prostate cancer, and by and large for women, it's breast cancer with a smaller proportion of cervix cancer and other cancers. Next slide.
So to understand the situation of radiotherapy access in Cameroon and in Africa in general, we have to look at the IAA recommendations, which state that each country should have 4 radiotherapy machines to 1 million people, ideally, and a minimum of 1.5 per million people, ideally. So taking the United States, for example, they over-exceed this recommendation with an average of 13.2 radiotherapy units per million. So looking at Cameroon with its population of about 29 million, we are supposed to have a minimum of at least 40 radiotherapy machines in the whole country with an ideal number of 116. But unfortunately, currently we have just 2 machines, and one of which is an outdated cobalt unit, which has been in service for over 20 years. And then we have a recently established privately owned LINAC machine. It's also worth noting that there is no brachytherapy available in the country. Next slide, please. So this diagram is really familiar to most of us in the rad-onc field, but it really illustrates the global distribution of radiotherapy infrastructure and highlights the difficult situation of Africa in comparison to other countries. So when you look at the countries in green, which are mostly North America, Europe, Australia, and some parts of South America, they have the best availability of radiotherapy access with ratios of 1 unit per less than 500,000 inhabitants, compared to Africa, where you have many countries in red without any access to radiotherapy at all. And the most you can get to acceptable levels of access is only in South Africa and Egypt, where you have ratios of about 1 unit to 500 to 1 million people. It's also worth noting that in some of these countries in green, they even have radiotherapy access to pets and animals, whereas in Africa, a lot of countries don't have such access. Next slide, please. So just emphasizing the difficult situation of radiotherapy access in Africa by stating that the African continent has the least amount of radiotherapy resources. With its population of over 1.2 billion, ideally we should have a minimum of 1,800 radiotherapy units on the continent. But from 2020, the Global Can statistics indicated that there were only 430 radiotherapy units on the African continent. And like we highlighted, most of them are outdated cobalt machines, and a majority of these, almost 60% of these, are found only in South Africa and Egypt, leaving about 29 African countries without any radiotherapy access. Next slide, please. So focusing on Cameroon, like we've stated already, we have just 2 radiotherapy units in the country. The first one is a cobalt machine that is state-owned. It's found in Douala General Hospital. The picture shows a visit of one of our volunteers in 2016 to this facility. And in terms of the quality of radiation therapy that's offered here, there are no custom fields. We use only standard blocks. And in terms of accessibility and affordability, it's really difficult. First of all, because of frequent machine downtimes, and also because of long waiting times for the patients who are referred to this unit. There's supposed to be a second unit in the same facility, but it's been out of use for many years because of issues of moisture and water. So the private facility that was recently established is a LINAC machine. It's privately owned, but it's very cost prohibitive for most of our patients who cannot afford it. The University of Yaoundé is supposed to also have another cobalt machine, but these have not treated any patients for the past 10 years. Next slide.
So Mbingo Hospital is located in the northwest part of the country of Cameroon. It started as a land donated by the fawn of the region for leprosy patients, and over time developed into a general practice unit, and then over time into a tertiary care facility. Next slide. The hospital is located at about 4,500 feet, and you can see that there are mountains and waterfalls around the area, which are going to become important later on in this talk. It's a 310-bed facility that has both surgical and internal medicine, pediatric, and adult care. Next slide. You can see in the left-hand corner that Cameroon is the picture of a rooster. We are located in the tail of the rooster, just north of the capital known as Bamenda. We are quite rural in our location, about an hour drive from Bamenda. Next slide. Mbingo Hospital has roughly 650 staff with 23 full-time physicians. We see about 46,000 outpatients a year with roughly 5,000 admissions and 5,000 major and minor surgeries. There are two medical oncology staff that are here full-time, and two pathologists, one trained in the US and one in Kenya. We have both general surgery as well as some subspecialty surgeries present. And in our internal medicine department, we have access to endoscopy, a CT scanner, clinics related to HIV care, TB, Hansen's disease, and we have the outpatient oncology service. We have a head and neck surgery fellowship, an internal medicine and surgery residency program. We have a UND1 University resident in pediatric surgery, and we are now looking at expanding our cancer program. Next slide. We have about 26 visiting faculty last year from around the world, and 7 international residents joined us for between a week and 3-month rotations. Next slide. The cancer program here at Mbingo started in 2003 with the World Child Cancer Organization. In 2007, we had both the Pan-African Academy of Christian Surgery residency program, which has a minimum of 3 international faculty at any one time. In 2007, Dr. Tom and Edie Welty started the Women's Health Program throughout the Cameroon Baptist Convention Health Services, which was focused on screening for cervical and breast cancer. In 2008, here at Mbingo, the Cameroon Internal Medicine Residency Program started, and the community said they did not have cancer until we had a pathologist come to Mbingo, and all of a sudden in 2010, we were having diagnoses of cancer. The Adult Oncology Service and the Nurse-Led Palliative Care Service was organized in 2017, and in 2023, Dr. Ntumsi joined the other medical oncologist, Dr. Francine, and then a year later, we had a 3rd medical oncologist into the Cameroon Baptist Convention system down at Natingani in pediatric oncology. We see roughly 1,000 new adult cancer patients a year here at Mbingo, and we are now trying to help not just be a surgical service and a chemotherapy service, but expand care to include radiation oncology. Next slide.
All right, so Mbingo Baptist Hospital serves as a unique service area, like previously highlighted. It's found in the rural parts of northwest Cameroon, with all the other services that are available. The thought that establishing radiation therapy on the facility was feasible and was going to improve our chances of having comprehensive cancer care on the facility to enable every patient to get the care they need in the same place. So the idea was initially birthed by Dr. Dennis Palmer, who is the pioneer dean of the Christian Internal Medicine program at the Baptist Institute of Health Sciences. And in 2016, an initial visit was made to Yaoundé, where he encountered the Prime Minister, the then Prime Minister at the time, as we can see on the picture, to pitch the idea to the Prime Minister. And there was a lot of support from the Prime Minister. But during this visit, they also had the opportunity to encounter medical students at the University of Yaoundé 1, where they did presentations and planned for collaborations from the University of Yaoundé 1. They also had an initial discussion with the National Radiation Protection Agency during the meeting. Next slide, please. So these are just pictures of the 2016 meeting. This is in the University of Yaoundé 1. Next slide. And then this is a meeting to the Douala General Hospital, where they visited the lone cobalt unit that's available in the country. Next slide.
This is the reference for all of what we're going to be discussing today, both the story behind and the story going forward. Next slide. So after that 2016 visit, there were monthly Zoom meetings that involved different disciplines depending on the issue that was being worked at the time. So the on-site specialists included hospital administration, the dean of the BIHS, different oncology representatives here at Mbingo, and there were remote contributions from civil and structural engineers, radiation oncologists from Europe and North America, medical physicists, nuclear medicine specialists, and radiation therapists. Next slide. One of the issues that had to be dealt with involved the availability of a steady power supply. And in 2021, we were fortunate with the aid of a grant from USAID to develop a hydroelectric power plant using that waterfall capacity that was described earlier. It also provided an opportunity to design some water to the compound that is especially needed during the dry season. So this massive project was started, was undertaken, was completed during the height of the civil conflict in this part of the country, and no lives were lost and there were no major injuries. Next slide.
All right, so the vision of our project is to provide comprehensive cancer care to everyone who comes to our facility. And our initial intention is to treat every patient that comes, regardless of their ability to pay. This is something that we've practiced with other aspects of care that we've been offering in the facility, you know, from chemotherapy, from surgery. And we anticipate that subsequently we'll get a lot of patients from neighboring countries who don't have access to radiation therapy. Next slide. So the potential of the project, approximately we are seeing about 1,000 new cancer patients in Mbingo Baptist Hospital every year. And it's estimated that between 60 to 70% of these people will require radiation therapy at some point during the course of their treatment, maybe for palliation or for curation. And this will translate to an approximate number of 15 patients treated per day in the facility. But as earlier highlighted, we anticipate that there will be a huge influx from neighboring countries. And things that will facilitate the progress of this, we need patient hostels to enable patients who live far from the facility to stay on the compound and receive treatment during the course of their treatment. And there's ongoing construction of patient hostels already, as we'll see in the subsequent slides. Next slide. So regarding the timeline of the project, in May 2019, an initial submission was made to the Cameroon National Radiation Protection Agency to apply for authorization to commence construction of the bunker. The initial designs were approved, and then in January 2020, a topographical site survey was done. And then eventually in September 2020, the civil drawings were submitted to the Cameroon Baptist Convention for pricing. And then in March 2022, a donated LINAC machine was decommissioned in Wales and then shipped to Cameroon, and this arrived in June 2022. Next slide. So in terms of the radiotherapy equipment, we currently have a used variant 2100C donated from Wales, which is currently on site at Mbingo Baptist Hospital. And recently, we've been contacted by the University of Heidelberg regarding further donations. And I mean, the question will arise as to why not get a brand new machine. Now, this is a very expensive endeavor that we are shouldering by ourselves, and so we know the costs of brand new machines. But other considerations that we took are that the donated machine had a very low use and was in complete service during its history in Wales, and has had very meticulous maintenance. So issues around return to service after a potential power outage will be less complicated because the most common faults and their resolutions are already known for the machine. And it was also anticipated that initially we would have very limited on-site technical support, and so having a machine with already known history will be easy for troubleshooting and returning to service. The spare parts for the machine are also available, and these were included for shipment for the machine. Next slide, please. Now, this is the bunker design that was submitted for approval at the Cameroon Radiation Protection Agency. Next slide. It's planned to house 2 machines initially. So the considerations for the bunker design, they took into account the 8 months wet season in designing the roof loading, and a historical assessment of the earthquake risk was made, and it was found that 2 earthquakes have happened around the vicinity of the site. The initial one was a 4.8 magnitude earthquake that happened in 1987, and then the latest one was 4.2 in 2005. They also considered very stringent tolerances for the wall design, the ceiling, and the height to allow for a differential settlement after alignment of the LINAC equipment of less than 0.2 millimeters per year. They have done revisions on the concrete mixture to avoid the use of expensive art mixtures, but retaining good concrete strength and workability. And we've employed the services of a local firm to do the material testing and ensure that we are working within the prescribed allowances. The cooling system was also designed, taking into account the local humid and hot climate in the area, and the official construction began in January 2023, and we currently have weekly construction site meetings to evaluate any challenges to construction and the progress with the construction. So the completion of the bunker construction is expected in October 2025. Next slide. So these are just pictures to give highlights on the progress of the construction. So in February 2023, the excavation of the site was completed. Next slide. And then in March 2023, the foundation's footings were placed, but we experienced some delays because we did not have a large mixer. And then there were initial issues around water availability in the area. Next slide. So these are the walls of the foundations that were being raised in March 2023. Next slide. And then by November 2023, the foundation of the walls and backfilling with earth was completed. But we had significant delays due to road closures that arose as a result of the civil conflict that's ongoing in the area. Next slide. These are pictures showing placement of ducting for the LINAC electricals, but also placement of the floor slab. Next slide. And then between July to November 2024, we had another delay in construction, and this arose from issues around reviewing the contract, the cost of the contract, but this was sorted out. And then from November 2024, the construction of the bunker walls commenced. Next slide. And so March 2025, this is the current state of our bunker. The bunker wall construction is ongoing. Next slide. So it is not enough to just supply LINAC to a low and middle income country. The most important thing is to foster growth and support on every aspect required to run a radiotherapy machine, taking into consideration the infrastructure in a low and middle income country. Next slide. So regarding the maintenance, the plans for maintenance on the LINAC machine, there's an on-site electrical engineer who will get remote support from third party that will be provided as needed. In terms of the radiation oncologist, I just completed my training in December 2023 and joined the program, but we are hoping to have more people go for training. The big issue around training in Cameroon is that there is no established training for any of the workforce that's required to run the program. And so if you want to run a program, then you have to send people out of the country. And also because there is very limited radiotherapy work happening in the country, a lot of people are not motivated to come back because there's no employment. And even regarding the salaries, it's not encouraging. So we've earmarked candidates for formal training in India, and we'll have 2 candidates earmarked for that. And then we have 3 candidates earmarked for radiation therapy training in Uganda. And we plan to send them sometime at the end of the year. So the initial dosimetry work, we plan to do it remotely, taking into consideration the financial constraints that we have. And we are currently having discussions with Varian and Ray Station about having a donated treatment planning system. The other issue that we are facing is the significant financial constraints. And so we've tried to connect with the International Atomic Energy Agency to see if we can benefit from support. But the way the IAEA works, they work directly with government institutions. They don't work with non-governmental institutions. And the current situation in our country is that our government has not ratified agreements with the IAEA, so it becomes difficult to benefit from the IAEA. Next slide.
The dream or the vision is that this would be a comprehensive cancer care delivery unit, and that would require having a place where all of the staff can meet with the patients in one site rather than spread across the compound. So when funding is available, we do have the design for the Cancer Care Center building, which would be located next door to the bunker. Next slide. As was previously mentioned, we've completed almost construction on the first of the 4 units that are planned for patient hosteling. These are 1 and 2 room units that have a self-enclosed washroom and kitchen facilities, as well as a place for sleeping and small living area. Next slide. So as mentioned before, there is some funding that is already in place and has been used for the work and the education that's gone on up until this time. That has been through grants, through private foundations, through donations and in-kind support. We do not work on the project if the funding is not there, so we're still raising funding for the patient hostels, the other 3 units, for the Comprehensive Cancer Center, and for the shipment of the second donated Linac machine. Next slide. This is, I hope, a comprehensive list of everyone that's been involved to date, and I apologize if I've missed any names or organizations. Next slide. There is a preliminary website that is been posted as listed there. Next slide. If anyone is interested in helping us with donations, there are currently 2 sites to which funding can be provided. This 3rd site that's kind of pale at the bottom is an educational site that we hope to have up and running for radiation. It's currently running for patient care, for staff education and nursing and surgery at this time. Next slide. So we thank you for your attention, and we'll try and take any questions that you have.
Thank you very much. You have some additional resources there as well, which is brilliant. Thank you so much. Let me stop sharing. Great. Wow. I mean, it's phenomenal what you've achieved and what you are achieving, I should say. Yash, I'll stop talking and hand over to you to take the questions. I have quite a lengthy list of questions here myself, but I'll hand over to you for the questions.
Michelle, and thank you very much for our presenters that about all the great talk, and actually that I just have one quick question. I saw that someone from the audience got their hands up as well, and maybe we'll let our audience to ask the question first. I think Timothy.
I think it's Brandon, might be the first name, is it?
It might be. I don't know. Or we can have a Brandon and put that and the questions on the Q&A. I think that would be great. And so I think the first questions that I have that from our author is and definitely your work at MBH is definitely very inspiring. I'm just wondering that what key factors do you think that make your project successful? And do you have any advice that you were able to give to your neighboring countries if they want to following your inspirational project to set up a radiation therapy program in the local hospital? I think you're on mute.
My first comment to your question is that this is not one individual or one group that gets together to build a mountain. It takes many specialists with many different gifts, and they come in and out over periods of time. As you saw, they've been meeting since 2017, which predates even my being here at Mbingo. So it is not a quick and easy vision to see come to fulfillment. It takes many partners. It takes investment, not only of time, but also of finances. And everybody has something to offer, whether it's fundraising, whether it's civil engineering, whether it's becoming a new staff in a novel area. So it's a long road forward as a partner.
Just to add that the multidisciplinary dimension to our project is really very important, because it also helps us to prioritize the most important things. And from the initial discussions, it was really discovered that one of the things we needed to address first was power, because we don't have regular, reliable power in Cameroon, and that's something that is essential to run a sophisticated machine as like a LINAC machine. So from those multidisciplinary discussions, we put our priorities together and we push forward to establish sustainable power on the facility.
That's great. Thank you. Thank you very much for your insight. I think that come really well, from the question from the audience about, is it radiating hope? Is the way that, for us to get involved in the United States? I'm just great to, have your comment on that.
Okay, I think we have some initial support from Radiating Hope, but it's not in terms of finances, it's more in terms of human resources. So we're getting a lot of support in terms of advice and a willingness to eventually come as volunteers for the initial phase when the LINAC machine is established and to assist with its operation.
Thank you. And I just have one follow-up question that before I pass on back to Michelle. I think these are cheeky questions because I think, there's a questions that I've been thinking and I think is sometimes I feel like, maybe a bit too much, if I ask, but I think your paper and also your presentation really highlighted, the disparities for the radiation therapy access that, either between the, the LMICs and high-income countries or just even within Africa. And based on experience in Cameroon, what do you think the key policy changes or the international collaborations it will be crucial for us to address these disparities?
I think there are many.
I know that it's like, it's just out there, but I think it's just really good to have your insights.
Yeah, I think that there are many things that need to be addressed. I think the first thing is the fact that we do not have universal health coverage. And so a lot of our patients still have to pay out of pocket. And so when they go to, for example, the privately owned LINAC facility, it becomes very cost prohibitive for them. But I also think that cancer care needs to become a priority on the government's health agenda. And we need a lot of advocacy. We need to get our policymakers involved to see the need to invest in cancer care in the country.
Definitely, thank you. I will pass on to Michelle because I just want to say that it's truly inspirational, the project that the team been doing, and I think you definitely mentioned something that I think we may take it for granted, for basic like the power supply, So I love that how you really address that, actually before we get the machine in, you want to stable, the power supply, and for that project. Get that the power supply to be established in your local area. I think that is definitely a big task. So thank you very much. I will pass on to Michelle for her questions.
Thanks, Gat. My questions are probably very practical because I'm just trying to think about being a therapist or working in a facility in your region. I'm trying to put myself there. Just when you mentioned lastly there, Ntumsi, about putting cancer care on as a priority of the government. I mean, I'm just trying to understand the picture in the country. I mean, I assume there are other competing is probably not the right word, but other maybe diseases that are are they higher up the chain, if you like, in terms of the government priority, would you say? So is that's an issue, I gather, from your nodding.
Yeah. So, I mean, infectious diseases have historically been the main focus in terms of our priorities, from HIV/AIDS to malaria to tuberculosis. And so a lot of the foreign support that has been coming in has been focused to address those issues. And we know the surrounding circumstances about international aid recently.
Yes.
And taking away support for HIV would mean that the remaining amount of money that the government has, they'll have to prioritize HIV care.
Yeah.
Also, just talking about universal health coverage, there are ongoing conversations about having that. malaria. So cancer care still seems to be down on the list of priorities.
Mm. And then, Laurie, if I could ask you, because you're a gynecologic oncologist, so there's no brachytherapy, no, so I'm just thinking about the women who have cervix cancer, and you said cervix cancer is one of the main cancers in the country. I mean, what are we talking about for mortality from cervix cancer in Cameroon then?
So here at Mbingo, one of our students did their master's thesis and showed that most women are living between 1 and 2 years after diagnosis, which shows you that they're presenting with advanced stage. They're either just getting palliative care or palliative treatment with the radiation. For those women that we are picking up earlier, if I can operate on them, I do offer that. But in terms of the radiation that's being offered, it's usually pelvic radiation with a central boost. If they don't get the central boost, then there's discussions about doing a clearing hysterectomy if the timing is right. If they've waited too long, I can't do that. So that's currently what treatment is, and the radiation is combined with chemotherapy.
And so it's very so having had radiotherapy with a central block followed by a clearing hysterectomy, obviously the toxicity and for these women must be immense.
Not only that, but we don't have PD-L1 inhibitors or anything like that in this country. We don't even have the lab to be able to do that workup.
It's very sobering, and I think Ntumsi, you made the comment at the start when you showed the map of the world about people in this part of the world, not necessarily in this country, but in other parts of the world who have radiotherapy for their animals. I mean, which is quite astounding when you say it like that with what we're discussing at the moment. Sorry, Yat, I don't want to take all the time. I'm just checking no one else has their hand up. I was also wondering a little bit, I have 2 other questions and then I'll stop because actually I have about 10 questions, but I'm not going to keep asking them all. Just again, something very practical about, and you said you have an engineer, you're planning to have an engineer on site, because this is something that we've heard through another project that I'm involved with in the IAEA called AfroNet RTT, where we have online webinars for radiation therapists from Africa. And of course, I'll link up with you afterwards to share details of that, because that could be helpful. But one thing that we've had a lot of discussion about are the service contracts. And particularly if you're bringing in a unit that's been decommissioned from somewhere else, it's not coming from a vendor. And I know you said you'll have parts, but I'm just trying to think about, and then you have intermittent power supply. I'm thinking about, are you hopeful for online support? Is that even feasible if you have an intermittent power supply, or how do you think that could work?
All right, so those are conversations we've had about having a service contract, and for decommissioned machines, you'll not be able to get it from the main manufacturer. You have to get it from a second or third party. So there's actually a company in Turkey that helped us with decommissioning the machine, who are also interested in providing a service contract.
Okay. That's good to hear, because we hear that very, very often, from when we ask the question, what happens when the machine breaks down? The answer typically we receive is nothing. That's it. So it's extremely difficult. I was just wondering as well, coming back to and you made a really valid point, both of you, about it's not just, when for LMICs, it's not just, here, let's land the machine in the country and nothing is around to support. And I think you mentioned some training of radiation oncology staff in both India and Uganda. And I'm just wondering, how are you funding that? Because, that is not a cheap solution, to have to send people for training for a long period of time to other countries. Is that being funded through your funding you currently have, or how will that happen?
So our first medical oncologist was honored with quite a large fund called the Le Champ. And so part of that is being tracked for the training for these individuals. Part of it was put in other domains, but this is funding that comes into the hospital to acknowledge the great work that she's done. That's Dr. Francine Kuya.
Mm-hmm. Okay, thank you. Thank you very much. Yash, I'm going to hand back to you because I think I've asked about 4 or 5 questions now. But it's just fascinating. Thank you all so much. I mean, it's incredible what you've achieved, even seeing the project with the dam. I mean, I was just, in my mind, I was just thinking, how was it even logistically possible? It just looks so complex. So congratulations. And we look forward to hearing about your progress in the future and of course, to assisting in any way that we possibly can. Okay, Yash, back to you.
Yeah, that's okay. I think before I ask half my final questions that for the authors, I just want to encourage our audience that and I know the chat function that's been disabled because we have the Q&A functions, and also that I know that because of the presenter mode that we're not able to give everyone for the microphone access. So I would just encourage that everyone to please use the Q&A functions to put down your questions. And if we're not able to answer all your questions that through the webinar, we're definitely able to do follow-up as well with the authors. So and I think the questions that I'm following with Michelle's and discussions with our authors, I just quite keen to know about and for your presentation as your paper you mentioned about the training program. So we're focused on the recruitment part, but for both for your papers and presentation, you do mention another piece that is about how do we retain our colleagues in your local settings, and because and I think yes we overcome the first hurdle that getting the funding, having that and identify that the kind of the talented colleagues to be trained. Do you have any plan that how do you able to retain them in your local hospital to really that bring back the service to your local populations?
In both the SIMS and the PACS program here on site, the tradition is that their training is given for 4 to 5 years, and then they give back for that 4 to 5 years to one of the Cameroon Baptist Convention health services. So that is a long-standing tradition here. I assume that's going to be part and parcel of what is happening for the radiation training.
So, I mean, everyone who is chosen to go for the training signs a training contract, and they're expected to come back to the country. But then you cannot completely guarantee that. Obviously, you're going to get some good people and you're going to experience some losses, but you do your best. But I think also we try our best to select people who buy into the vision of the program, who see the burden of cancer care in Cameroon and want to come back. But also we also try to create an environment where people feel comfortable to work and comfortable to grow in. Especially that we anticipate that after the initial training, we would also want to establish on-site training in the facility, because we've established that for programs like surgery and internal medicine and public health, but eventually we would want to get that to oncology. So the initial people will be sort of the pioneers to run such a program.
Great, thank you. I promise there will be last questions there, because I feel like that and we keep asking you both questions. I feel really, really bad about it, but I think just really keen to have your insight. I think for this project or for this program that you mentioned about, and the team getting, support, from our, either international agency, IAEA and WHO, and also you got a lot of volunteering support. And how about the, you've able to share insight about how do you engage with the kind of the global leaders, in terms of vendors, no matter it's about a pharma or, and for radiation therapy, the equipment vendors. Do you get any, engagement with them to get the support that you need, or do you have any lessons learned that you were able to share with our audience?
Oh, all right. So everybody on the multidisciplinary team has this presentation that we just did, and we find opportunities during conferences and other occasions to present on the project and sell the idea. So that's mostly what has been happening now. We have people with contacts in Varian who also pitch the idea to them and other companies like that, but we've not really engaged pharmacological companies and things and other groups like that.
Thank you. And I think that, I didn't see any more question from the Q&A yet, and just before we kind of pass on by Michelle to close the webinar, I just don't know that, and Ntumsi and Dr. Laurie, that do you have anything that you want to share with our audience, before we kind of, close the webinar?
So I'll just say thank you very much for giving us the opportunity to share what we are trying to accomplish here in Cameroon, and any sort of support that we can get to make this a reality will be very much appreciated. Thank you so much.
Thank you. Thank you both so much for sharing. And I think it's just so, as this whole special issue was about, it's just so important for people to stop thinking in silos of, I think about what we think of radiotherapy here, and how we are so concerned about really minute details. And I think you've just really put things in perspective for us, and hopefully for our audience who've read your paper, and also who have attended today, and also who can listen back to this on our website within the next couple of weeks. So thank you very much indeed for joining. Yash, thank you for co-chairing with me. And I want to thank the staff at Elsevier for setting up the webinar. And I wish you all a wonderful rest of the day. Bye-bye.